Assalamu alaikum wa rahmatullah. Welcome everyone. My name is Raneem A Almutairi and I'm going to be continuing to discuss nutrition and Ramadan fasting for diabetic patients. So first of all, the estimated number of Muslims around the world is up to 2 billion Muslims. So globally, there are more than 20 million diabetic people who fast during the month of Ramadan. Therefore, addressing their specific needs and how they can adjust to fasting is of paramount importance to ensure that their blood glucose level remain under control during Ramadan. So approximately about 43% of patients with type 1 diabetes and up to 80% of patients with type 2 diabetes fast during Ramadan. So fasting during Ramadan is obligatory on every adult Muslim except those who are severely ill, and they fast approximately between 29 to 30 days. So they fast in approximately 14 hours during the day in general in most countries around the world. So we will start by discussing the physiological state of diabetic during the month of Ramadan. First of all, carbohydrate metabolism in healthy persons, as most of the studies showed that there is a slight decrease in the serum glucose to up to 3.3 and even to 3.9 millimoles that occurs in the normal adults a few hours after fasting has begun. So changes in the serum glucose may occur in individuals depending upon their food habits and individual differences in their metabolism and energy regulation, regardless of even if they don't have diabetes. Second is the body weight, as the weight losses in Ramadan is approximately to be 1.7 up to 3.8 kg that have been reported in normal weight individuals after they have fasted for the month of Ramadan. So even some studies has showed that there is no slight change or even slight increase in weight depending upon the dietary habits of the individuals. In addition to this, the blood glucose variation in patients with diabetes does develop, as most patients show no significant change in their glucose control at all. But some patients, their serum glucose concentration may fall or even rises, leading to unstable glycemic state. In addition to this variation may be due to the amount or the type of food that is consumed, their regularity of taking medication, their energy after the fast is broken, or even their decreased physical activity in the month of Ramadan. In addition to this, their glycated hemoglobin level values show no change during Ramadan, but only 2 studies have reported a slight increase in the glycated hemoglobin level, and also the amount of the fructose amine, the insulin, the C-peptide has also been reported to have no significant change before and even during Ramadan fasting. This is in the normal, in the diabetic patient rather than the normal individual. So insulin secretion in healthy individual is stimulated with feeding, which will promote the storage of glucose in the liver and the muscles as glycogen. While in contrast to this, during fasting, the circulating glucose level tend to fall, therefore leading to decreased secretion of insulin, and the levels of glucagon and the catecholamine will rise, as therefore stimulating the breakdown of glycogen while the gluconeogenesis is augmented. So as fasting becomes protracted for more than several hours, then the glycogen stores become depleted and the low levels of the circulating insulin will allow an increased fatty acid release from the adipocytes. So the oxidation of these fatty acids will generate ketones that can be used as fuel by the skeletal muscles and the cardiac muscles, in addition to be used for energy resource in the liver, the kidney, and the adipose tissue. Therefore, sparing the glucose for continued utilization by the brain and the erythrocytes. So some of the major risks that are associated with fasting in patients with diabetes include hypoglycemia, hyperglycemia, as well as rebound hyperglycemia, diabetic ketoacidosis, dehydration, and thrombosis in some cases. So in the case of hypoglycemia, it has been estimated that hypoglycemia accounts for up to 4% of mortality in patients with type 1 diabetes. So the recent EBDR study showed that the fasting during Ramadan increases the risk of severe hypoglycemia up to 4.7-fold in patients with type 1 and up to 7-fold in patients with type 2 diabetes. While in the case of the development of hyperglycemia, it will increase in 5-fold in the incidence of severe hyperglycemia, therefore requiring hospitalization in patients with type 2 diabetes in specific. While in patients with type 1 diabetes, it will increase 3-fold the risk of having severe hyperglycemia with or without ketoacidosis in patients with type 1. While for diabetic ketoacidosis, the patients with diabetes who fast during Ramadan are at increased risk for the development of diabetic ketoacidosis, in particular if poorly controlled before Ramadan. So the risk may further increase due to excessive reduction of the insulin dose based on the assumption that food intake is reduced during this month. So having pre-Ramadan modified nutritional intervention and controlling diabetes is of paramount importance. In addition, dehydration and thrombosis are suspected or possible complications. So the reports have suggested an increased incidence of retinal vein occlusion, but the hospitalization due to coronary events or stroke were not increased during Ramadan. So limitation of fluid intake during the fast, especially if it was prolonged, is a cause for dehydration in most patients. In addition to this, hyperglycemia can produce an osmotic diuresis, therefore, it will contribute to the volume and the electrolyte depletion. So most often the recommendation will be not to undertake fasting if you have poorly blood glucose levels before Ramadan. However, patients who insist on fasting need to be aware of the associated risk and be ready to adhere to the recommendation of their healthcare provider to achieve a safer fasting experience. So the categories of risk in patients with type 1 or 2 diabetes who fast during Ramadan are divided into first, very high risk, in which there is a severe hypoglycemia within the last 3 months before Ramadan. Also patients with a history of recurrent hypoglycemia, in addition to patients with hypoglycemic unawareness, or those having acute illness or pregnant women, in addition to patients on a chronic renal dialysis. Also, those who are considered to be at a very high risk are patients with sustained poor glycemic control, in which their A1C level is more than 9. Second is patient with ketoacidosis within the last 3 months before Ramadan. And in general, patients with type 1 diabetes who are, of course, dependent on insulin, in addition to hyperosmolar hyperglycemic state within the previous 3 months, and patients who perform intense physical labor in addition to having diabetes. While those who are considered to be at a high risk only are patients with moderate hyperglycemia. Their average blood glucose level is between 8 and 16 millimole, and their A1C level is 7.5 up to 9. Also, patients with renal insufficiency, in addition to those living alone and having uncontrolled diabetes, or even on a medication that may affect their mental abilities. In addition to this, patients with advanced macrovascular complication and patients living alone that are treated with insulin or sulfonylureas, as well as patients with comorbid conditions which possess the additional risk factor, also having older age with ill health in general. While those who are classified to be at a moderate risk are those having well-controlled diabetes who are treated with short-acting insulin, sigrafolos, and those who are to be considered at a low risk are patients with well-controlled diabetes and are being treated with medical nutritional therapy, metformin, acrobose, and any other type of increment-based therapies in otherwise healthy patients. So the main principles of the pre-Ramadan consideration are physical well-being assessment, assessment of the metabolic control, also adjustment of diet protocol for Ramadan fasting, and adjustment for the drug regimen, including the change in the long-acting hypoglycemic medication to the short-acting medication to prevent hypoglycemia, as well as encouragement of continued proper physical activity and the recognition of warning symptoms of dehydration, hypoglycemia, and any other possible complications that can develop. So first of all, the recommendation include the nutritional and fasting consideration for the diet, in which the patient should abstain from high caloric and highly refined food prepared during this month, as this will lead to a very high increase in the blood glucose level immediately after fasting, and then half an hour to even 1 hour after breaking the fast, the blood glucose level will return to normal or even to a hypoglycemic level, therefore negatively affecting their homeostasis for the glucose level. Also, physical activity assessment should be assessed, as it has been shown that fasting doesn't interfere with the tolerance to exercise, but it is necessary to continue their usual physical activity, especially during the non-fasting period, to have a better control. Some other tips for the health for reduction of complication include implementation of the 3D triangle of Ramadan, in which the drug regimen adjustment, the dietary management, and the daily activity as the three pillars for more successful fasting during Ramadan. So the diabetic home management that consists of monitoring the home blood glucose, especially for type 1 diabetes, also checking the urine for acetones, in addition to measuring daily weight and informing the physicians of weight reduction, including dehydration, low food intake, polyuria, or even weight increase with excessive caloric intake above 2 kilograms. Also recording the daily diet intake and the prevention of excessive and very low energy consumption is recommended. Also, we should educate the patient about their warning symptoms or signs of dehydration, hypoglycemia, as well as hyperglycemia, and educate them about breaking the fast as soon as any complication or new harmful condition develops. In addition, immediate medical help for diabetic patients who need medical help quickly rather than waiting for medical assistance for the next day, therefore ensuring that the patient have the required medical attention when it is immediately required. So for the medical education in diabetic patients, this is regarded as the READ program for those with type 2 diabetes during Ramadan. They should focus, the objective is focusing on the meal plan and the dietary advice, as diet during Ramadan shouldn't differ from the healthy balanced diet. Also to encourage a slow energy release of foods such as having wheat, beans, and rice, and to minimize the food which has a high content of saturated fatty acids, such as sambusa or any other type of fried food. And for exercise, it is recommended to take light and moderate exercise on a regular basis and avoid any high intensity exercise during the evening time because of the risk of developing hypoglycemia. And regarding the medical assessment, we should encourage the patient to seek medical advice from their general practitioner before Ramadan with regarding to any necessary medication change or dose adjustment. And in general, for diabetes, they should always have careful blood glucose monitoring. In addition to the patient who should fast should know how to test their capillary blood glucose level and encouraging them to test their own glucose levels when they are feeling symptoms or being unwell. And they should also be educated how to recognize and manage any possible complications, such as how to recognize the major symptoms of hypoglycemia and hyperglycemia, also how to manage hypoglycemia for patient safety, and stressing on the break of fast when hypoglycemia occurs. So the benefit of education and counseling, according to the READ study, is that it increased 4 times their blood glucose control and reduced the hypoglycemic event. So for the management, the general consideration consists of having several important issues that deserve special attention. These include individualization according to the patient's specific needs and their blood glucose values, also the frequent monitoring of hypoglycemia, in addition to nutrition, exercise, and breaking the fast. Another important consideration is the adjustment of medication. So before Ramadan, the patient on diet and exercise, which is the medical nutrition therapy, should be treated. Sorry, just a second. So the patients who are on a diet and exercise should have their diet assist. And during Ramadan, there will be no changes needed in their diet medication, and also to modify just the time and the intensity of the exercise and ensure that the patient have adequate fluid intake. And the majority of type 2 diabetic patients are treated with sulfonylurea and metformin. Therefore, before Ramadan, if they were taking sulfonylurea once daily in a morning dose, then this should be taken after the iftar with the full dose as well. But if they were taking twice a daily dose, then they should take this at the iftar and also at the suhoor time. And if they were taking metformin 500 milligram on a daily basis, then during Ramadan, this should be divided into two doses, one taking at the iftar and the other at the sahur. So for every medication that is being consumed before Ramadan, there should be a certain adjustment. Therefore, before Ramadan, all diabetic patients who are taking medication should contact their physician in order to assess if any adjustment is needed. So the management, which is specific for patients with type 1 diabetes, as the fasting can carry very high risk for people with type 1 diabetes, the risk is particularly increased in poorly controlled patients and those with limited access to medical care. In addition to those having hypoglycemic unawareness, unstable glycemic control, or recurrent hospitalization. So the risk is also very high in patients with who are unwell or unable to monitor their blood glucose level several times during the day at home. So if the patient chooses to fast against any medical advice, then it have an advantage if they are on a basal insulin regimen uh, and also being familiar with the carbohydrate counting method. So a small study of 9 patients only with type 1 diabetes using insulin glargine and insulin lispro or aspart, which are divided into 6:4 ratio of the total 24-hour insulin dose. They reported no episodes of severe hypoglycemia or that of a diabetic ketoacidosis, therefore doesn't require hospitalization, and their A1C level remained stable at the end of Ramadan as well. In addition to this, a recent small study with insulin glargine suggested that relative safety and efficacy of this agent in 15 relatively well-controlled patients with type 1 diabetes, fasting for 18 hours and experiencing minimal decline in the mean plasma glucose from 125 to 90, with only 2 episodes of mild hypoglycemia. While in another study in patients with type 1 diabetes using insulin glucagon or lispro on a regular insulin combination with intermediate acting injection twice a day has led to improvement in the postprandial glycemia and was associated with fewer hypoglycemic events. So, continuous subcutaneous insulin infusion pump with the management is an appealing alternative strategy, but having a substantially great expense as well on the patient. So, the recommendation during pregnancy, some of the pregnant women who are diabetic as well are exempt from fasting, and they should be strongly advised to not fast during Ramadan. And these women who constitute on a high risk group and their management require intensified care. So, management of hypertension and dyslipidemia include having dehydration, volume depletion, and tendency toward hypotension, which may occur with fasting during Ramadan. Therefore, the dosage of the antihypertensive medication may need to be adjusted to prevent any hypotension. So, it is common practice that the intake of food which is rich in carbohydrate and saturated fat is increased during Ramadan, and having appropriate counseling should be given to avoid this practice in general. While in the post-Ramadan supervision, the patient therapeutic regimen should be changed back to the previous schedule, and patients should also be required to get an overall education about the impact of fasting on their physiology. So, having degenerative complication check-up and having monthly weight, blood pressure, A1C, and renal function tests conducted every 6 months or every monthly for the weight and blood pressure is recommended. So, patients should also monitor their blood glucose even during fasting to recognize any subclinical hypo and hyperglycemia. Also, Islam allows diabetic patients to have regular blood tests while fasting, and if their blood glucose level is noted to be very low, less than 60, then the fast must be broken. And if their blood glucose level is noted to be very high, over 300, then they would have ketones in their urine checked and having medical advice checked. So, in conclusion, the majority of the uncomplicated type 2 diabetic patients can fast during Ramadan with minimum risk. Also, the pre Ramadan medical assessment, education, and motivation are very important to prevent diabetic patient or diabetic related complications. And fasting along with regular prayer have been proven to aid in the better control of diabetes, and having individualization with frequent monitoring of glycemia can significantly reduce the major risks which are associated with fasting. Another important consideration during Ramadan fasting for diabetic patients is the assessment of patients with gestational diabetes. We will start by discussing what is gestational diabetes and how it can implicate fasting. So, GDM involves glucose intolerance with the first onset or recognition during pregnancy. So, it can affect 14 up to 25% of all pregnancy, and it has been found to increase over the past decade. So, in general, pregnancy in itself is considered to be a metabolic stress status. And during the first half of pregnancy, transfer of the maternal glucose to the fetus develop. And during the second half of pregnancy, the placental hormones outweigh the glucose transfer and also the insulin requirement, which will typically double. So the placenta will function as a nutrient sensor, therefore altering the placental transport according to the maternal supply of a nutrient, and having placental transporters which are regulated by hormone such as insulin. And the insulin resistance occurs with the gestational hormones such as human placental lactogen, which will interfere with the insulin action in general. So the accelerated fetal growth in women with diabetes is characterized by increased activity of the placental and glucose transporters. And the cell signaling for insulin changes in GDM for women with diabetes or GDM that may need to have one or twice daily more insulin than other pregnant women in general. So all pregnant women should be assessed for the risk of GDM at the first prenatal visit, and most of whom are screened between 24 and 28 weeks of gestation. So one or more of the following factors identify a woman who is at risk for GDM. So the first is the ethnicity as Hispanic American, African women, Asian, or Pacific Islander, and American Indian has been found to be at increased risk. So family history of diabetes in a first degree relative, parent, or sibling will also increase the risk, as well as gestational diabetes or the presence of a birth defect in a previous pregnancy. And four is the history of a pregnancy-induced hypertension with UTI or hydroammonase, which is an extra amniotic fluid. In addition to this, having history of abnormal glucose tolerance, having an older maternal age, pre-pregnancy overweight or obesity, having previous birth of a large baby, or previous stillbirth or spontaneous miscarriage will all increase the risk of having gestational diabetes. Also, hyperglycemia in pregnancy causes many complications and the risk for the infant, such as macrosomia, neural tube defect, hypocalcemia, hypomagnesemia, or hyperbilirubinemia with birth trauma or prematurity, or even neonatal hypoglycemia. So having a daily SMPG is important as the fasting glucose level shouldn't exceed 105, as well as having an excellent blood glucose control with diet, as well as when necessary insulin that will result in improved prenatal outcome, and assessing the A1C testing, which is not useful in GDM in specific. So, women with a previous history with GDM and obesity are at a significant higher risk of developing metabolic syndrome. In addition to, there is a higher risk of hypertension, preeclampsia, urinary tract infection, C-section, and future diabetes development. Also, about half of the women who have GDM will proceed to have type 2 diabetes later, especially in women who are hypertensive. So nutritional recommendation should be based on a thorough nutrition assessment, in addition to monitoring the blood glucose level, urine ketone appetite, and weight gain that will guide the individualized nutrition prescription and meal planning. Also, adjustment should be made or to the meal plan throughout pregnancy to ensure that the desired outcome is reached. So the glucose testing for GDM, as it often present with hyperglycemia and glycosuria, also having selective screening at 24 and 28 weeks of pregnancy is generally recommended, and with a glucose challenge test and 1 hour assessment using either 100 gram glucose or 75 of oral glucose testing, in addition to having two or more of the venous plasma glucose concentration that must be met or exceeded for a positive diagnosis. So the test should be done in the morning after an overnight overnight fast in general to assess for the level. So according to the American Diabetic Association criteria for GDM, in the one-step approach, they should perform a diagnostic oral glucose tolerance test without having prior plasma or serum glucose screening. Also, the one-step approach may be cost-effective and having higher risk for patients or the populations. While in the second step approach, they should perform an initial screening by measuring the plasma or the serum glucose concentration, in addition to having 1 hour after 50-gram glucose oral load, in addition to performing diagnostic OGT on the set of women who exceeded the glucose threshold on the GCT testing. So when the two-step approach is used, a glucose threshold value of 140 should identify approximately 80% of females with GDM, and they yield further increase to 90 by using a cutoff of 130. So these are the values for the glucose loading test after a couple of hours after the test. We will just be taking a quick 5-minute breaks and then continue our discussion. So, as we were saying, in women who have had bariatric surgery, a close nutritional evaluation will be needed. So, deficiency in iron, vitamin A, B12, and K, in addition to folate and calcium, can result in both maternal anemia and fetal complications. So, such as congenital abnormality, intrauterine growth retardation, and failure to thrive. So the offspring of women with GDM are considered to be at increased risk for respiratory distress, macrosomia, jaundice, hypoglycemia, in addition to hyperinsulinemia, birth trauma, and developmental problems. So development of metabolic syndrome in late adolescence and young adulthood is related to the maternal glycemia in the third trimester, in addition to maternal obesity, neonatal macrosomia, and childhood obesity. So even though that treatment of mild cases of GDM doesn't significantly reduces the frequency of stillborns, having prenatal death or severe neonatal complication does reduce the risk of fetal overgrowth, shoulder dystocia, C-section, and hypertensive disorders. So obesity, insulin resistance, and abnormal lipid metabolism bear ominous consequence for the future generation. And after birth, having rapid adaptation is necessary for infants to be able to maintain independent glucose homeostasis. And this is compromised in infants who are small for gestational age, premature, or are larger for their gestational age. So for women who are offered treatment for mild GDM, in addition to routine obstetric care, additional charges are incurred, but fewer babies experience any serious prenatal complication or even death. So nutritional intervention for GDM saves thousands of dollars per case, as well as all women with GDM should receive nutritional counseling by the registered dietitian. So medical nutrition therapy should be initiated within 1 week of diagnosis and with a minimum of 3 nutritional visits, and it can result in decreased hospital admission and insulin use, improving the likelihood of normal fetal and placental growth, as well as reducing the risk of prenatal complication, especially when diagnosed and treated early on. So the objectives for the intervention are to prevent any complications, prevent prenatal morbidity and mortality by normalizing the level of glycemia and any other metabolites. This should be reduced to the level of non-diabetic pregnant individual to ensure the best outcome for the infant and their mother as well. In addition, we need to optimize the growth and the development of the fetus to the desired maternal weight gain that will vary according to the pre-pregnancy weight and the current weight gain in general. So the optimal weight gain is generally as the following. During the first trimester, the weight gain should be between half to 1 kg. Also in the second trimester, it should be, and the third as well, it should be between 0.2 to 0.5 kg for every week in general. In addition to this, we need to ensure that we prevent any weight loss for pregnant women, even if they have diabetes, but rather we should only control their weight gain. So in obese women, they should control the weight gain carefully, as we have mentioned, and having excessive weight gain may be a forerunner for the metabolic syndrome in the fetus later in life. In addition, we need to prevent infections and any unexpected outcome for the maternal and having the fetal glucose exposure and the consequence fetal insulin secretion that is normally tightly regulated by glucose and the delivery from the mother during pregnancy. So the risk for the spontaneous preterm birth increases with increasing the level of the pregnancy glycemia, and we need to control the blood pressure as well as avoiding any incident of starvation ketosis where the glucose is needed and the diabetic acidosis where the insulin and the potassium are needed. So this can be avoided by having regular pre-pharyngeal and post-pharyngeal spontaneous medical glucose testing and having ketosis that is harmful for the baby and should be prevented at all times. So using insulin when necessary based on measures of the maternal glycemia with or without assessment of the fetal growth, as well as insulin therapy that is recommended when the nutrition intervention fails to maintain fasting of the whole blood glucose at a desired level. So preventing hypoglycemic episode, UTI, and candidiasis is of paramount importance at all times during the pregnancy, and promoting healthy lifestyle change for the mother as well for the latest long after the delivery as well to ensure that they don't develop type 2 diabetes later on. So women with GDM should be encouraged to breastfeed as well, as this can help them to control their blood glucose level as well as to return to their pre-pregnancy weight. So physical activity, especially after meals, can help to maintain the blood glucose control, and having some contraindications to exercise can include pregnancy-induced hypertension, intrauterine growth retardation, preterm labor, or even history of preterm labor, having incompetent cervix or persistent second or third trimester bleeding should be regarded as signs to avoid exercise in general. So for food and the nutritional intervention in pregnant women, we should use a carbohydrate controlled meal plan with adequate intake to keep the weight gain appropriate while preventing glycemic shift or ketonuria, as well as managing for age and weight goals. Also providing adequate energy and the nutrient to meet the needs of the maternal blood glucose goals, which have been established, is of paramount importance, and this should be followed even during fasting during the month of Ramadan. So the typical diet should include between 30 to 35 kilocalorie per kg. This should be calculated as 20% from protein, 45% from carbohydrate, and 35 up to 40 uh, for fat. Also, selecting carbohydrate from whole grains, one fruit portion or one milk portion at a time is recommended. Also, we need to limit juice, sweets, or even desserts. So having sufficient carbohydrate intake is needed in a minimum of 175 gram at a minimum. So many women with GDM will undereat out of fear of needing insulin, as well as interval weight losses may indicate the presence of ketones fasting. So insulin may be needed in some cases until their blood glucose values are stabilized. So while a low glycemic index diet may be beneficial for some outcome or even for both the mother and the child, the results are still inconclusive at this time in regard to their use. So for obese women with a BMI over 30, having caloric limit of 25 kilocalorie per kg is recommended of the actual body weight per day. So this has been shown to reduce hyperglycemia and the plasma triglyceride level with no increase in the ketonuria. So for many women, this translates to an energy intake of around 1,700 kilocalorie to 1,800 kilocalorie. So even during Ramadan, we should ensure that pregnant women consume this amount of carbohydrate or calories, sorry, in order to ensure that they have the best outcome for the baby. Also, having artificial sweeteners may be used, but not saccharine in general, and they should be limited and only used when needed in most cases. So maintaining adequate intake of polyunsaturated fats will keep the saturated fat to 10% of the total fat or even less if possible. And most women would require 3 meals and 4 to 5 snacks per day. Snacks are eaten at least 2 to 3 hours between feeding and should contain carbohydrate. So during Ramadan, this should be translated to 2 or even 3 meals in a day and having 1 or 2 snacks between fasting, breaking the fast, the iftar and sahur. So having smaller, more frequent meals and snack will be beneficial because of the insulin resistance in general. So working closely with the dietitian to establish the best pattern according to the typical blood glucose level is recommended. And having a snack before bedtime may be needed. This can be a cup of milk before sleeping or consuming some yogurt to ensure that their blood glucose values are maintained in a homogeneous status. So DASH diet principle may be helpful if the blood pressure is elevated, and it can include regular use of antioxidant foods such as spices, including cinnamon, which has been found in some studies to improve their blood glucose control. Also, ensuring the intake of prenatal vitamin and mineral supplements, especially those containing 600 grams of folic acid and 30 to 60 milligram of iron, of vitamin C, and adequate calcium is recommended in most cases. Also, including adequate chromium intake from the diet, as in the yeast bread, is recommended as it has been found to improve the glucose control and the homeostasis. So tube feeding may be useful in patients who cannot be fed orally or having hyperemesis. So carbohydrate controlled products are not necessarily required, but should be monitored carefully. So after the delivery, a review of glucose tolerance and postpartum nutrition is suggested at 6 to 12 weeks after the baby delivery to ensure that the patient have the best outcome afterward and avoid the development of type 2 diabetes. So some of the common medications that are used as investigators found that there is no substantial maternal or neonatal outcome difference between the use of glycopyrrolate or metformin compared with the use of insulin and GDM. So as long as we have a healthy baby and a healthy mother, then the type of the medication or the use of insulin doesn't present an important problem, but rather our most important focus is on the control of the blood glucose values. So insulin may be required to control blood glucose if diet and exercise doesn't help at all. In addition to this, careful physician and self-monitoring is important in most cases. So the insulin lispro is associated with fewer hypoglycemic events and the use of prenatal vitamin or mineral supplement as pre-prescribed is recommended in all cases. So avoiding any large doses of vitamin C can show a false positive urinary glucose level, and more than 200 milligrams is not needed in most cases. So having a low dose of estrogen progesterone oral contraceptive may be used after GDM if there was no medical contraindication. However, if medications that worsen insulin resistance, such as glucocorticoid or nicotinic acid, should be avoided if possible. Regarding the use of herbs and potential supplement, in general, pregnant women shouldn't take any herbs and potential products, and they should discuss their concurrent use or previous use with their physician. Also, supplementation of vitamin D may influence the glucose metabolism in GDM by increasing the insulin sensitivity. But more research is needed on the postpartum requirement to make an informed decision. So only limited evidence exists to support the prenatal omega-3 supplementation, but using it with caution during the first 2 trimesters of pregnancy, that is in the DHA without any additional monitoring of the amino acid supplementation can be indicated. In addition to this, conflicting evidence has been found regarding the specific nutrients, such as zinc and selenium, which seems to be protective, whereas chromium doesn't. So more research is needed for micronutrient recommendation to be made in this regard. While for nutrition education, the registered dietitian should monitor and evaluate the blood glucose, the weight, the food intake, and their physical activity values, in addition to pharmacological therapy if indicated in patients with GDM at each visit. So medical nutrition therapy results in improved maternal and neonatal outcome in general. So communicating the importance of the meal spacing, the timing of the meal, and the adequacy with the consistency of the type of the meals that is consumed, such as the patient that shouldn't skip meals, is of paramount importance and should be educated to the patient in their visits. So instructions on what to eat and what to avoid will be important in all cases. And carrying a snack at all time is helpful, such as fruit, a cracker, or peanut butter stick. Also, following the current dietary evidence based guidelines is recommended for all patients. In addition to this, having regular aerobic exercise such as walking is beneficial, and exercising after meals can help in controlling the blood sugar level, but we shouldn't exercise until the patient is short of breath, but rather having mild to moderate strength exercise. Also, we need to encourage the patient to breastfeed to return to the pre-pregnancy weight and ensure for homeostasis in the blood glucose level. So babies who are born to women with GDM may also have low levels of lipids such as arachidonic acid and DHAs, but further studies are needed to ensure that we have the required supplement intake in these children. Also, we need to encourage family planning and ensuring optimal glucose regulation for all subsequent pregnancies in general. And for women with history of GDM that are more likely to have current diabetes if they are older, heavier, and wait even longer between pregnancy, in many cases has been reported. So reoccurrence of GDM is common, especially among non-Caucasian population, but counseling regarding the risk of type 2 diabetes is recommended in all patients. So any degree of abnormal glucose levels, homeostasis during pregnancy will independently predict an increased risk of glucose intolerance and CVD in the postpartum period. So elevated fasting blood glucose, oral glucose tolerance testing, 2-hour blood glucose, and oral glucose levels of A1C are considered to be as strong and consistent predictor of the subsequent type 2 diabetes development risk. So having long-term lifestyle modification, also maintenance of normal body weight and physical activity should be discussed for those type of patients. And discussing the potential impact of GDM on the offspring who are at increased risk of obesity, glucose intolerance, and diabetes in later adolescence or adulthood is recommended in order to ensure that the mother is motivated to have the best outcome for their babies. So for patient education regarding foodborne illnesses, if the patient was using home tube feeding, then we should teach them on appropriate sanitation processes and food handling processes in this case. So in the case of preeclampsia, which is defined as the association of a pregnancy-induced hypertension and proteinuria after 20 weeks of gestation is the definition of preeclampsia. So it is more common in the premature and also patient with multiple gestation, type 1 diabetes, teenage mothers, and family with history of the disease and age over 40, or having underlying vascular or renal disease. So this can affect up to 8% of pregnancies and is considered to be a severe complication which may lead to fetal morbidity and mortality if not controlled well. So the risk for the baby includes poor growth and prematurity. Also having preeclampsia can lead to problems in the liver, kidneys, brain, and the clotting system. So the maternal morbidity includes placental abruption, the HELP syndrome, which is hemolysis, elevated liver enzyme, and low platelet levels, or eclampsia, and their treatment consists of ending the pregnancy in most cases. So early sonogram is recommended, and many women will have to have total bed rest during their entire pregnancy to ensure that the best outcome for the child is maintained. So the severe preeclampsia, which develop at 34 weeks of gestation, is associated with high prenatal mortality and morbidity. And women who are 37 weeks pregnant are induced immediately to ensure that no complication develops for the baby. So the criteria for having a mild preeclampsia include hypertension, which is defined as 140 over 90 or up to 160 over 109. Also proteinuria, mild edema with weight gain, and urine output that is more than 500 milli for every 24 hours. So these criteria defines the development of a mild case of preeclampsia. So other signs and symptoms include having increased blood pressure, having proteinuria, facial edema, brittle pitting edema, and irritability, nausea and vomiting, nervousness, headache, altered state of consciousness, epigastric pain, and oliguria. So the criteria for the severe cases of preeclampsia include having blood pressure that is more than 160 over 110, also on a two successive occasion with patients who are on total bed rest. Also having high systolic blood pressure rises over the baseline and their diastolic pressure increases over 30 of the baseline. So proteinuria in addition should be present with more than 5 grams in 24 hours or 3 to 4 urine dipstick with massive edema and oliguria that is less than 400 in 24 hours. So these symptoms define the development of a severe case of preeclampsia in patients with gestational diabetes. So these signs and symptoms include having pulmonary edema, having as well severe headaches, visual change, right upper quadrant pain, elevated liver enzyme, and thrombocytopenia, in addition to the two symptoms that were listed before for the preeclampsia, the mild cases. So in the eclampsia, a seizure can develop. And in eclamptic seizures, the symptoms of the HELP syndrome occurs, which we have discussed earlier on. And in severe cases, there may also be hepatic rupture, pulmonary edema, with acute renal failure or placental abruption, and elevated creatinine levels with intrauterine growth restriction, cerebral hemorrhage, cortical blindness, and retinal detachment in the severe cases that can be present. So the maternal mortality rate in this case is 38 up to 36%. And because the plasma concentration or the homocysteine level is often increased, then having sufficient intake of folic acid level, vitamin B12 and B6 is recommended. Also, studies have showed the effectiveness of having magnesium supplementation in the eclamptic and pre-eclamptic patients. So the objectives for the intervention in this case include reducing the maternal and the neonatal mortality and morbidity. Also, in pregnant patients with diabetes and chronic hypertension, the blood pressure target was is 110 to 130 over 65 up to 80. So avoiding lower blood pressure because the fetal growth may be impaired, therefore maintaining somewhat of a normal blood pressure levels in order to ensure the best outcome for both the mother and the fetus. So reducing the edema when present, correcting any underlying malnutrition or micronutrient deficiency is recommended by making the appropriate assessment in these cases. And as this can be a severe case and can have significant complication on pregnant diabetic mothers, in this case, fasting during Ramadan should be discouraged in most cases. And if the mother insists on fasting, then they should fast for a couple of days while assessing their blood glucose values to see if any complication does develop. And if so, then they should stop their fasting until their blood glucose values normalize and try then afterward. So monitoring any sudden weight gain that are unexplained by food intake is recommended as an assessment procedure for assessing the presence of edema. Also preventing, if possible, any chronic hypertension and metabolic syndrome after delivery. So the common medication used as the only intervention that is shown to prevent the preeclampsia are antiplatelet agents then having a primarily low level or dose of aspirin, in addition to calcium supplementation and magnesium sulfate or for the eclamptic seizures is recommended. In addition to this, avoiding excessive magnesium from supplementation if this medication is being used should be assessed to avoid any possible complications. And if corticosteroid is recommended for lung maturity, they can be necessary, but in this case, we should also assess for the development of hyperglycemia, in specific with fasting after breaking the fast at the iftar. So during pregnancy, a typical diuretic and cardiac drugs are not used, but having ACE inhibitors and ARBs are contraindicated in this case. And using calcium pump inhibitors are often the first line of choice in this case. And for herbs and potential supplements, they shouldn't be used in pregnancy at all to avoid any possible negative impact on the fetus. So using evening bromazole has been suggested for this condition, but should be used under careful medical evaluation. And having CoQ10 enzyme and the alpha tocopherols, which are potent antioxidant, can be used in some cases. While for the nutrition education and counseling in the care management, rest is essential during this time, and having biofeedback, yoga, meditation, and any other forms of stress reduction are often beneficial in most cases. Also, meal skipping should be avoided at all costs, and having regular intake of meals with spacing, with snacks, and also consuming a cup of milk before fasting is recommended in this case. In addition, we need to discuss adequate sources of calcium from the diet, especially if there was dairy products that are not tolerated or preferred. Also, having a good source of potassium and magnesium, including nut, fruit, and vegetables, is recommended. In addition to this, following the DASH diet is considered to be an excellent diet to continue even after pregnancy to ensure the return of the blood glucose values to normal. So if the patient was using home tube feeding, then we should teach them on appropriate sanitation practices and food handling procedures. While some of the potential complications in this case of diabetes include as well hyperglycemia, and the symptoms include polyphagia, polydipsia, polyuria, and dehydration, in addition to weight loss, weakness, muscle wasting, reoccurrence or resistance infection, hypovolemia, ketonemia, glycosuria, or blurred vision, in addition to muscle cramps, fatigue, and having a dry mouth. So blood glucose level of 250 milligrams should be evaluated, in addition to monitoring the blood or the urine ketones to check for any diabetic ketoacidosis development. So there are three forms of hyperglycemia that may be noted in the hospitalized patients. These include someone with a history of diagnosed diabetes, previous unrecognized diabetes, or having hospital-related fasting blood glucose of 126 milligram per deciliter, or a random blood glucose value of more than 200 which revert to the normal after discharge. So DKA, or non-ketotic hyperosmolar state, in which the stress of the illness, trauma, or surgery frequently aggravate the glycemic control and may even predict DKA, or non-ketotic hyperosmolar state. So a vomiting illness accompanied by ketosis may indicate DKA, which is a life-threatening condition that require immediate medical care to prevent complications and death. So cerebral edema can occur in this case, and having early consultations with an endocrinologist is needed. So we should educate the patient about the signs and symptoms of hypoglycemia, including shakiness, confusion, diarrhea, irritability, having hunger, weakness, or even headache, in addition to rapid and shallow breathing as signs of hypoglycemia. And in this case, they should measure their blood glucose level. And if they are actually very low hypoglycemic, then they should break their fast. Other symptoms also include numbness of the mouth or lips, having a pulse that is normal or abnormal, and having convulsions or lack of coordination and dizziness in the severe cases is regarded as a sign of hypoglycemia. In addition, having pallor, slurred speech, tingling or diaphoresis, nausea, sweating or tremors, in addition to nightmare or hallucination, are also signs of hypoglycemia. So we should treat when the blood glucose level is less than 70 with 15 grams of liquid or fat-free source of glucose or carbohydrate. And we should afterward wait for 15 minutes and assess the blood glucose level again. If it was still less than 70, then we should treat with a second round of 15 grams of carbohydrate or sugar source. We should continue to monitor the blood glucose level until the next meal and until the blood glucose level is stabilized. So adding a protein source to the carbohydrate doesn't affect the glycemic response and doesn't prevent the subsequent hypoglycemia, but adding fat can retard and then prolong the acute glycemic response in general. So in rare severe hypoglycemic cases in which the individual requires the assistance of another person and cannot be treated with oral carbohydrate, then having an emergency glucagon kit can be used in this case. So an important symptom that can develop in diabetic patients is the Down phenomenon. And this is particularly important during Ramadan fasting. So this phenomena is the end result of a combined natural body change which occurred during the sleep cycle. So this occurs between 3 a.m. and 8 a.m., in which the body naturally starts to increase the amount of counter-regulatory hormones, such as growth hormone, cortisol, and catecholamines. So these will work against the insulin action to drop the blood glucose levels. So these will cause the blood sugar level to rise in the morning as it counteracts the insulin mechanism. So after this phenomena, there is the Simuji effect in which a rebound hyperglycemia leads to a high blood pressure level in the morning that precedes an episode of asymptomatic hypoglycemia. So when the blood sugar level drops too low in the middle of the night, the body counteracts the releasing of these hormones by raising the sugar level in the body. So too much insulin earlier or not enough on the bedtime snack can be the problem for the development of this condition. So regarding the acute illness or infection in which any condition that lead to deterioration in the glycemic control will necessitate more frequent monitoring of the blood glucose and the urine or the blood ketone levels. So having aggressive glycemic management with insulin is needed in the case of severe acute illness. Also, the risk for DKA is higher during this time, and having blood glucose testing and drinking enough amount of fluid and ingesting, most importantly, enough amount of carbohydrate is recommended. So if the blood glucose levels are too low and adjusting the medication to keep the glucose in the desired range and also preventing any starvation of the ketones is recommended as a monitoring and assessment method. So in acute illness or infection as well, having a marked hyperglycemia requires temporary adjustment to the treatment program. And if it was accompanied by ketosis, having frequent interaction with diabetes care team is also encouraged. So in the severe cases, hospitalization may be needed until their blood glucose values are normalized. And in the case of pediatric cases, having cerebral edema can develop and should be referred to pediatric oncologist, endocrinologist for evaluation and immediate care. Also, vaccination with annually influenza vaccine to all diabetic patients over the 6-month age is recommended, and providing at least one lifetime pneumococcal vaccine for adults with diabetes is also recommended. So for persons who have diabetes, they tend to be at a higher than the normal risk for bacterial forms of pneumonia. So in the critically ill patient, having their blood glucose level should be kept as close to 110 as possible, and generally 180 of intravenous insulin is usually needed for these cases. So scheduling a parenteral insulin dose should be given in relation to meals and also should be adjusted according to the point of care of the glucose level, as well as having the traditional sliding scale insulin regimen may be effective and are useful in some cases. So some of the intermediate potential complications for children with type 1 diabetes include growth and development, which may be impaired with diabetes. Therefore, having adequate protein and energy must be provided. Also, children can be picky eaters, and therefore, children or adolescents in general can be picky eaters, and therefore, their blood glucose values need to be assessed before allowing them to fast during Ramadan. So their target range for normal blood glucose value are somewhat less strict than that of adults in order to ensure that they have sufficient growth. So having a near normalization of the blood glucose level is seldom attainable in children and adolescents. Also, after the honeymoon or remission period, it should be assessed generally. So their A1C goals are also very valid in children, but most of children under 6 or 7 have a hypoglycemic unawareness. So to recognize their response to hypoglycemic symptoms, they need to be monitored by an adult. So children with diabetes will differ from adults in many ways, including insulin sensitivity and any related effect to their sexual maturity, physical growth, and ability to provide self-care, in addition to vulnerability and hypoglycemia effect. So working with the family and school to plan for emergencies such as low or high blood glucose level is recommended in all cases. So distinction between type 1 and 2 diabetes in children can be difficult because of the autoantigens and the ketones that may be present. So children with type 2 diabetes are usually overweight or even obese and present with glycosuria with or without ketonuria. So absence or mild polyuria and polydipsia with little or no weight loss can be indicated. And up to 33% will have ketonuria at the time of diagnosis, but some may also have ketoacidosis without any associated stress or illness. So in the preconception state, all women with diabetes and childbearing potential should be educated about their need for good glucose control. So the need for family planning and the need for early treatment for diabetic retinopathy, nephropathy, neuropathy, or cardiovascular disease is recommended. So A1C levels should be normal or as close to normal as possible. And for pregnancy and diabetes, having infant mortality rates that are approximately twice higher for babies who are born to mother with uncontrolled diabetes compared with babies who are born to mothers without diabetes. So to reduce the risk of fetal malformation and maternal or fetal complication, pregnant women and women who are planning to become pregnant would require excellent blood glucose control. So having a specialized laboratory and diagnostic test may be needed, and women with diabetes must be trained in self-monitoring blood glucose. So nutrition recommendations for women with pre-existing diabetes must be based on a thorough assessment. So monitoring the blood glucose level, the blood or urine ketones, appetite, and weight gain is needed to develop an individualized nutrition prescription, and also to make adjustment to the meal plan. So the plasma glucose should be maintained at 65 to 100 before the meals, and in fasting, it should be 110 to 130. In addition to this, using an extra 300 calories per day is recommended. So this is only required during the second and the third trimester, or having an additional 25 grams of protein or folic acid supplementation is also recommended. In addition to this, adding iron and calcium may also be required. And in lactation, having extra protein, calcium, and folic acid will be needed. Also, monitoring for blood glucose is recommended. but hypoglycemia should be avoided in most cases. So breastfeeding will lower the blood glucose level and may require women to eat more carbohydrate-containing snacks either before or during breastfeeding. So having an extra 300 to 400 kilocalories will meet the need for most lactating mothers. In addition to this, in older adults, an unexplained weight loss should be viewed as a symptom of a problem. And in diabetes, it is an important health condition for the aging population. At least 20% of patients over the age of 65 will have diabetes. So these patients will tend to have a high rate of premature death, functional disability, and coexisting illnesses such as hypertension, heart disease, and stroke than those without diabetes. So modifying the medication rather than the diet is needed, and having lower hypertension will gradually implement the DASH diet whenever possible. So having a multivitamin mineral supplement may be beneficial for this population. While for the other chronic complications, these include retinopathy, in which it accounts for up to 12,000 and 24,000 cases of blindness each year. So having an optimal glycemic and blood pressure control can substantially reduce the risk and the progression as well of diabetic retinopathy. So in the presence of a proliferative diabetic retinopathy or a severe non-proliferative retinopathy, then this will lead to vigorous aerobic or resistance exercise can be contraindicated in this case because of the risk of triggering hemorrhage or retinal detachment. So in pregnant women with type 1 diabetes, they can aggravate retinopathy, and having laser photocoagulation surgery can minimize this risk. So in the case as well, some of the severe complications include microalbuminuria and nephropathy. And early signs of nephropathy include hyperfiltration, renal hypertrophy, and microalbuminuria. And the protein losses are at a rate of 300 grams of the creatinine, which may indicate advancement toward chronic kidney disease. So to reduce the risk or to slow the progression of nephropathy, optimizing the glucose and blood pressure control is required. And also the nephropathy is preceded by microalbuminuria for several years. So the onset of an end-stage renal disease is about 5 years after the onset of microalbuminuria. So for diabetic nephropathy, having liberalized carbohydrate intake and controlling insulin level accordingly. And controlling the protein intake will slow down the progression of nephropathy. And for adults who need zero point 0.8 to 1 gram of protein per kg on a daily basis. So the protein restrictions is of benefit in slowing the progression of albuminuria, the glomerular filtration rate decline, and also the occurrence of an end-stage renal disease. So protein restriction should be considered in patients whose nephropathy seems to be progressing despite the optimal glucose control and the blood pressure control. So the intensive diabetes management with the goal of achieving near normal glycemia has been shown to delay the onset of the microalbuminuria. Also, end-stage renal disease is a possible complication, and having diabetes, which is the leading cause of CKD, especially among Mexicans, Native American, and Blacks, is considered to be at a higher risk. So diabetic nephropathy occurs in 20 to 40% of patients with diabetes and is regarded as the single leading cause of end-stage renal disease. So creatinine and GFR should be assessed annually in this population, and their microalbuminuria and macroalbuminuria level should be carefully monitored. So while physical activity can acutely increase urinary protein excretion, there is no evidence that vigorous exercise increases the rate of the progression of diabetic kidney disease. While the autonomic neuropathy, about 70% of persons who have diabetes will have some degree of neuropathy, including impaired sensation in the hands and also the feet, in addition to slow digestion or carpal tunnel syndrome. So autonomic neuropathies can decrease the cardiac responsiveness to exercise, causing postural hypotension, impaired thermoregulation, impaired skin blood flow and sweating, as well as impaired night vision with impaired thirst, risk of dehydration, and gastroparesis with unpredicted food delivery. So neuropathy may be delayed with careful blood glucose management, and weight loss may be beneficial for obese persons to ensure the best glucose control. While for the skin and joint, a decreased pain sensation in the extremities may increase the risk of skin breakdown and also infection with joint destruction. So it may be best to encourage non-weight-bearing activities such as swimming, bicycling, or arm exercise. So diabetic autonomic neuropathy is associated with recurrent genitourinary tract disturbance or bladder or even sexual dysfunction. And the most prevalent one is having amputation with the lower extremities that are painful and disabling. Therefore, preventing them with having good control of blood glucose level is recommended. Also, foot ulcers are the most common consequence of diabetic neuropathy and other major causes of morbidity and disability in patients with diabetes. So thank you for your time. We have reached the end of our webinar for today. If you have any questions, please do send them on the chat. العفو بالتوفيق جميعا الله يعافيكم.